recording right away, so no. Okay, so yes, basically that we have that that in Parkinson's disease we need to boost the dopaminergic transmission, and in this case, to have less of this too much movement, we need to inhibit that dopaminergic tone. But I'm going to explain you how, right? So let me put something here, and yeah, boom. So we're going to start with chorea, and the difference between the three of them, the chorea, the atelectasis, and the valismus, is just where the movements are happening. Okay, and then we will see that in the circuits of the basal ganglia, they come from different parts, but at the end it's the same, or not the same, but it's very similar. So here I didn't want. I mean, I have some YouTube videos there that you can check. I mean, I have them there, but I don't want to put them. If you want to see how it really looks like in a video, you just put chorea in YouTube, and then you will get this kind of movement. So in chorea, what we will have is more pronounced at the distal part of the limbs, sudden movements, involuntary and irregular. And then the difference is in between some of them is that there is low amplitude, which is sometimes is different or is difficult to actually recognize it from a normal movement. It could be like a person is just doing something that it looks like he's deciding to do the movement, but then the patient is not conscious about this. Normally, chorea is unilateral, even though it can be also bilateral. And the muscle tone is most of the time diminished, which is also impressive that there is not weakness or sensory deficit, and the pyramidal tract signs are absent. The intrinsic muscle reflexes are normal, and they can have an overextension phase when the chorea is happening. So if we start from the beginning, let's put like we have enough movement, Parkinson's disease, too much movement, these hyperkinetic disorders. And in chorea, we would say that is mainly these distal movements and the end of the limbs that could actually most likely look like normal movements. And then we have the etiology that we have different diseases that they have chorea as one of the symptoms for one way to say. So we have one of the most common one with this is the Huntington disease, right? Huntington disease is a genetic disease that we're going to check it now, but we could have like some others like chorea minor. And this one is very tricky because actually what is causing this is a streptococcal infection, and it's most commonly in girls aged 6 to 13 years old, which is very worrying actually. Chorea mollis, the same, is autoimmune or streptococcal infection, and we can actually check all of these. But basically, what we need to understand in the pathophysiology is actually how is the map that we have seen with the Parkinson affected in each one of these diseases. So, Huntington disease is a genetic disorder that it has an unstable trinucleotide in the short arm of the chromosome 4. And here is the important. We have a loss of small ganglion cells in the putamen and the caudate nucleus of the in the basal ganglia. As I have said, these show motor dysfunctions. Some of them, they have cognitive impairment. Mainly when we're talking about Huntington disease later on. And then we have everything, depression, anxiety, irritability, etc. So to understand this disease that we're going to focus just a bit more because it's the most common one, is that we have this is the normal gene, and then we have extra or expanded trinuclear repeats of variable length in the chromosome, and this generates that mutation in a protein that Huntington, this protein Huntington, is a brain derived produce the brain derived neurotrophic factor BDNF, and also is for help of the transport, for cell addition, and we need it in the development of the nervous system. So here we're going to another protein that aggregates and another protein that generate damage in the brain. So we already have seen many of them, like what happened with tau in Alzheimer's disease. I mean, I have told you about that, what happened with tau in the TBI, and what happened in with Parkinson's disease with the alpha-synuclein. So this is something very common in our brain. So when we have these diseases, that the proteins start to aggregate. So the problem is that when we have this Huntington that is mutated, so this will have a polysequence, a sequence of polyglutamine that has toxic properties. And these toxic properties, for some reason, there will be, because these medium spinning neurons in the striatum are more vulnerable to them, so these neurons, they are going to die. And how do they do it? They do it like this, right? So we have the native Huntington, then the polyQ, and then we have this protein aggregation, where they start having impairment in proteostasis, impairment then protein aggregation also in the nuclei, and that will generate synaptic dysfunction, mitochondrial toxicity and energy balance, axonal transport impairment, and at the end, these neurons are going to die. Do we understand until now? Okay. So now it's good. Now comes the difficult part. Oh, no, that wasn't the next one, sorry. So, the treatment. It's a bad prognosis disease. It's normally, I think it appears, Huntington appears between 30 and 50 years old. And then in between 10 and 15 years after the onset of the symptoms, the patient will die. But we can treat this disease with inhibitors of dopamine. Mainly, what it has been to work is that, for example, tetrabenazine inhibits the vesicular monoamine transporter 2, the VMAT2, that is actually here. So this is a dopaminergic neuron, okay? Where do we have dopaminergic neurons? In the basal ganglia. What is the name of the nuclei that we saw in Parkinson?
De sustancia negra.
De sustancia negra. Okay, the sustancia negra. And then these dopaminergic neurons, so we need to actually diminish their activity. So what is happening that we have these drugs that actually block this transporter. for what do we need this transporter? Who can explain me this figure?
To recapture and be able to reuse the materials of the dopamine.
Exactly. So this is a recycling trafficking protein. Okay, so this is quite important. What it happens is that when the dopamine is recaptured from the presynapses, from the dopaminergic neuron, so it has two options. This dopamine, or it goes to the monoamine oxidase, which is going to degrade the dopamine, or will come to the to this transporter to go inside other synapse vesicles that they are about to release in the synapses. So if we block this, we will have less dopamine in our system to actually block to actually to actually avoid that hyper stability of what we're going to check now. Decreasing, so we have tetrabenazine, and then we have perfenazine, and then we have thioprid. That this also will inhibits the action of the vesicular transporter 2 and decreasing the ability of dopamine in the synapse. Or what we can go is all the way to block the dopamine receptors in the postsynapses. Okay, so that's one and the other. So here is what happens, and I want you to look at this for 2-3 minutes, 1 minute, and someone. So this is in the normal. This is actually the same motor, the same motor. How do you say? The same motor diagram that we have checked before. I actually found 3 different diagrams, so you will see the same diagram with in different ways, and just to see if I can actually try to that you have this picture in your head after this class. So this is the normal brain, and this is with a patient with chorea. Who can spot the difference?
There's like less inhibition, like the inhibition from the strand to the thalamus, like it's lower. So maybe that is what generates like the inability to control the movements that are happening.
So you're mentioning this one, right? Here.
Yes.
Yeah. We have one step before that.
It's kind of the same, like a thinner arrow from the striatum to the TPE, which I think it's the globus pallidus.
Yes, exactly, externus. So this is globus pallidus externus, and then we have the subthalamic nuclei. This is the subthalamic nuclei, and then we have here the globus pallidus internus, substantia nigra reticulata, and then this goes to the thalamus. So what happens here? So we have the substantia nigra that actually, if we go to the striatum here, so here we have the dopaminergic neurons, right? So sorry, here we have the substantia nigra compacta that has the dopaminergic neurons, and here we have the dopaminergic receptors, right? What is happening in Parkinson's disease? Who is dying?
The dopaminergic.
Dopaminergic neurons, right? So that's what is happening because of the Lewy bodies, alpha-synuclein, blah, blah, blah. So here, we don't have that effect. If we go back, here, right? So in this case, we have the loss of small ganglion cells in the putamen and the caudate nuclei. So basically what we have here is that in the striatum, we have less, so you see here in the striatum that we have like a huge inhibition to the globus pallidus. Then we have a normal, like another inhibition to the subthalamic nuclei, and then this excites this globus pallidus internus, and then we have an active like inhibition of the thalamus, and then we have the activation of the cerebral cortex movement. In this case, if we have that these neurons are dying, we have less inhibition, right? If we have less inhibition, then we will have that these cells will excite more the subthalamic nuclei. Sorry. And these, sorry, will have less excitation to the globus pallidus, which will reduce the activation of the thalamus, and this thalamus will over excite the cerebral cortex, and then we will have more movements than before. Does it make sense? If I say so, right? That it makes sense. Well, okay. So, yeah.
It from the part of the subthalamic nuclei. I got a little lost there. Like it's like because it's excited more, the other part is excited less.
Okay, so let's do this. If we're gonna say, and what I want you to get from Korea is that actually what we can do here, like because of the death of the ganglion cells here, then we have all of these mechanism out there, right? We're gonna see the next ones, and we're gonna see that actually different the next pathologies, they affect different areas of this circuit. So Laura, we go back after the explanation of all of them, and I think you will have a clearer picture of all of this, right? So something that I want you to really understand here is that we have the pathology, that is the loss of small ganglion cells in the putamen and the caudate nuclei, and then that we can treat this with the monoamine transporter, vesicular monoamine transporter 2, that like this tetrabenazine or the other tunes, or by actually antagonizing the receptors, the dopamine receptors in this part. I mean, I could ask you why the D2 and the D3 receptors, but that's why I wanted you to study the basal ganglia by yourself, because then we have that. If you remember, the D1, it will be for the direct pathway, and then we have the D2 for the indirect pathway. So we need to be actually careful which pathway we are inhibiting, but that's maybe too much. So, for example, now we're going to acetosis. So acetosis is a bit different since you have slow, continuing, and regular involuntary movements. That is just the ends of the limbs, which will cause an extreme flexion and extension of the joints. Okay, so this is what you can see here. Like the joints are the ones that are overextending, making these bizarre postures, and mainly in the hands. It also can involve the face, the tongue, and the neck, and the trunk. And what is lacking, so this is the rapid movements like you have it in Korea. So again, if you put these videos in YouTube, I mean, I have them there. I don't know if we can see them or you would like to see them, but that's what is a bit the different. It's in the clinic. So these are the clinical features: slow flowing movements in the distal part. These ones can vary in intensity and distribution. Actually, what they say is that the stress actually make it worse, and can happen at the same time, like in Korea or dystonia, other kind of movement disorders. And what is crazy is that when you're sleeping, this actually is absence. These features or these symptoms. Here we have another one. Here we have loss of neurons where? Globus pallidus, the striatum as well, and in the thalamus. So what do you think that is happening? So in the last one, we have that in caudate and putamen, we have less cells. So some small cell ganglion cells are dying here. Here also in this one, but then it's also in the globus pallidus. Okay, and actually, if we go to all the way, where do we have the thalamus here? Thalamus here. Okay. We have other so it can be congenitals, how this happening, like this loss of neurons, but also like stroke could make like if the stroke is actually affecting the basal ganglia, then you could get these effects. Or for example, traumatic brain injury also could generate this as a secondary effect. But it's the same thing. The same thing. We go back. We have the substantia nigra pars compacta that with dopamine comes here to activate like D1 or D2. Let's talk again about D2. The caudal putamen will actually, in this case, come to excite the globus pallidus externus and also the globus pallidus internus. And then here we're gonna, I mean, there's other ways to go to the spinal cord, but then we come to the thalamus, and then the thalamus will actually excite the motor cortex, and then we will start with the movement. So what happens here is if we have cell death here, then we have less excitation, and then here we will have hyperactivity of the thalamus, and we're going to come to the motor cortex. Okay, and then the motor cortex we're going to give us this effect. So, for example, if we go to the treatment, what do we need? Again, dopaminergic blocking agents, GABAergic medications to help with this. And actually, they have seen that if you go you don't go to the brain, but then you go to the muscle, like with this botulinum toxin, it can actually use to target these muscles. And here we start with the deep brain stimulation. So it's the same as in the Parkinson disease. So we just need to have the focal region of interest that we need. In this case, if we go to the globus pallidus interna, we could actually here make like around 50% of an improvement on these patients. Okay, so now we go to Valismus. Valismus, I mean, the name, it's going to be easier for you to remember, because in the Valismus, it's just like como una bala, right? So you have movements that they are more proximal in the joints, so mainly in the shoulder and the hip, and the movements are more violent. So you will have these movements that they go like this, right? So we have that in the chorea we have these kind of movements. In atetosis we have like more of the distal joints with this hand and finger movements, and then we have to the valism that is more sudden, right? They have an abrupt start, and they are involuntary as well, and actually can physically exhaust the patient these movements. And here we have again the same diagram, but in this case the lesion or where we are actually losing the cells is in the contralateral subthalamic nuclei here, right? So we have it here. We get rid of this nuclei, not that much, and this happened because of a stroke, hemorrhage, tumors, trauma, infections, etc. Who can tell me? Who can explain this again?
Oh, like is the one that has the X, the contralateral subthalamic nucleus?
Yeah. Yes, exactly. And this is the what happens in Valismus.
Is red excitation and blue inhibition?
Yes.
Okay. So I'm guessing since there's like the lack of well, a lesion in that specific region, it cannot excite the neurons from the globus pallidus enough in order for them to inhibit the thalamus.
Okay.
So there's an overactivation of the thalamus because they're lacking that inhibition.
Okay. Let's go again from the beginning. So substancia nigra, very good, Pamela. So can you continue to the same that you said, but just complete the map.
Okay, so sustancia nigra first, which is at the striatum, and then there's
With what?
with dopamine,
Yeah, great.
and which causes an inhibition of the globus pallidus externo, I'm guessing, and then that technically inhibits the the other part, the subthalamic nucleus?
Yep.
Well, I have a question there because if it's inhibiting it normally, wouldn't it have the same result as if they're not there? Well, or if they have like a lesion? If it's inhibiting their transmission of excitation, or am I being confused?
Yep. Okay. That's actually is good. So this is very dramatic. Like in this it's like if you lose all the cells, right? But then what we need here is to excite these cells, right? And if you are not exciting these cells to send the inhibition here, like then if you don't have excitation of these cells, they are not getting active, right? So here we don't have the cells, so we don't have who tell them to have inhibition to the thalamus. So then we have this strong activation of the cortex.
But like my
Yep.
question is, if the globus pallidus externus normally is inhibiting the subthalamic nucleus, wouldn't it still like lower the excitation of the globus pallidus internus? Interno? I don't know how to say it.
Yeah, no, it's good. The thing is, like with this inhibition from here, what we get is that the contralateral subthalamic nucleus will allow the excitation of the GPI. So if you don't have this, or if you don't have this one either, and that's why actually what I wanted to come to this part. If you don't have the neurons here to inhibit, what is happening here? We have, this is the
And
substance.
oh,
This is the
so
substance. Sorry, go, Pamela.
no, I was gonna ask. So the black here again is because I've been confused with the diagrams. But like, so the black here again is inhibition. I'm guessing so. It extra inhibits the subthalamic, and it causes an under activation of those neurons who excite the globus pallidus
Yeah,
interno. Yeah, okay.
you understand?
Like
And
that
then,
makes sense.
yeah. So this is the problem of I mean that's why it's I mean this is way more difficult to understand. But here we have the same. So we have that the inhibition. So this excitation inhibition excitatory part is what is helping us for the movement. So here you have the subthalamic nuclei, right? And then in this subthalamic nuclei, so we have that the GPA is gonna inhibit this, and when you inhibit this part because of here, so the problem is that we need to have like the balance between the excitation and the inhibition in the whole system. So if you remember that from I mean, I think we can actually go back all the way to here. So here we have it again, right? This is what happens in Parkinson's disease, right? So again, this is how it should. Where do we have it? Yeah, this is how we have it normally, right? Right? How it should work. And then when we go to Parkinson's disease, we have that the neurons here are dying, and then we cannot actually activate and deactivate, etc. And then we have the loss of movement. So it's depending where it's the lesion and where we are losing the neurons. But actually, and basically, the treatment, if we go to the treatment, is actually the same. Okay, we go to dopamine blocking agents. And then we have for other things, again, we have tetrabenazine that is gonna inhibit the transporter and reduce the dopamine. Here, we are gonna target also the globus pallidus interna, and you can actually lesion a bit these areas. But I'm gonna give you now, like, I want you to write this down. I know that you will have it, but if you write this part and then you ask me again your questions, then we can talk about this. Okay? So this is the pathophysiology. Write this down, please. Okay, done? Yes, Pamela?
Yes, I still have a question.
Yes.
So can you go back to the diagram?
Which one?
The one from this, the balismus.
Okay.
Okay, so like if in normal function, like I'm gonna say what I see in the diagram and then what I understood from you. Because like in normal function, it looks like the globus pallidus is inhibiting the STN, right? But if it's inhibiting it, like it would mean like the neurons are not doing their job, and if their job is to excite, they would not be exciting, right? If they're inhibiting the excitation neurons from the STN. So like what confuses me is that if normally they're inhibited, to me in my brain it would be the same result as if they were not working. However, what I understood from the past ones is that you said that it's like a balance, like that inhibition is not complete. That is like just to maintain a balance between how much like those neurons get excited. Because like it showed like two arrows in the other diagram that you showed.
Yep.
That it was like a inhibition excitation thing happening with the STN. So I'm guessing it like partially inhibits them just not to have an overreaction, but that's like my question. So I don't know if you understood my question. I'm sorry.
Kind of. No, I think I do. Kind of. So I think you have like over complete, like, no, how can I say this? Like, so you think that if this is happening, right? Then like if you don't have these cells, it would be the same, right?
Yes, maybe not the same, but yes, if it's inhibiting the STN or the normal pathways inhibition of the STN, how could it excite the GPI? If in the
Okay.
normal
Yeah.
pathway it's inhibited.
Yes. So then I think then we need to go here. right? So here we have something that is coming here. Just because I don't want you to go to the oversimplistic view of that diagram. So here, for example, we have these neurons that their work is to excite something, right? If we don't have the one that actually send inhibition to this to this one, we will have an overexcitation of this, right? And then if we have an overexcitation, we will have an overinhibition. So let's go to the, but these they need to be silenced, because then you have here, like, I mean, this is even though this is also a bit simplistic, but we have that other parts, all of these neurons are connected with other areas, and then in these ones they will actually excite this area of the brain. So in this case, what we need to have, like when we get, it's more a proper, like you can see maybe this as a proper activation of the GPI, because we have something also similar. The striatum, it has also a way of inhibiting the GPI, right? So if you have it here, like because of the dopaminergic blah 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 here, we have also diminished inhibition here, but we don't have actually the excitation. So what it comes here is a diminished activity of the GPI. What is the effect of the deep brain stimulation?
Stimulate the subthalamic nucleus mainly.
In this case, is here. Like if you remember here in the treatment, we are going to the globus pallidus interna. So we are going to try to actually stimulate this region. The problem, Estrella, here is that we cannot actually activate this one. Why?
Because it's damaged by a lesion.
Exactly. So we don't have neurons that actually help us. So we need to jump this part, right? So if we jump this part, then we can actually we can generate the inhibition of this, well, the excitation of the GPI with the brain stimulation, and then we can increase the inhibition to the thalamus and to have a normal motor function. And in this case, we have this big excitation to the motor cortex, and then we have this part. So maybe here, it was the there is one here missing. Oh, no, sorry. Okay, so that's it. So Laura, for example, we come to Cory as well, and then the neurons that they are dying here in the striatum, right? We can maybe in this case, instead of having the cross here, we're gonna have less here in this part, right? So then we're gonna have all of this diminished due to that part. So you have to think that we have the indirect and the direct pathway in both of these. So we can, at the end, what is the final effect before going to the thalamus? This, right? So this is what we need. So how come the substantia nigra compacta can actually excite and inhibit at the same time the striatum?
Because of the receptors it targets.
Exactly, because of the D1 and D2 receptors, right? But at the end, what we need, even though it's the direct or the indirect pathway, we need to actually generate like a balance, a excitatory inhibitory balance here to communicate with the thalamus, to communicate with the cortex. Okay, and this is actually what happens also in Parkinson's disease. It's just different mechanism. So if we make a diagram of all of this, we have to put that, for example, if we are talking about the Huntington or the chorea, we have the loss of cells in the striatum. If we talk about atelectasis, we have loss of neurons in the striatum, but also in the globus pallidus. And even we can have a less cell death in the thalamus. And then if we go to the valismus, we're going to talk about the contralateral subthalamic nucleus, the subthalamic nucleus. And that, what it's actually generating is that this like oversimplistic view of less activation of the GPI, which will not generate enough inhibition of the thalamus, which will generate more like these sudden movements. So we have them here. I mean, not in this one, but in this one, right? So we have more connectivity to the cerebral cortex, more movement going down. What is happening in Parkinson's disease? In this
That the substantia nigra is the one degrading, so like both routes are not being properly activated, and that causes a lack of like anything like good inhibition or excitatory responses.
Yep, exactly. So that's what happens. So that's why they are different. Why we have in one lack of movement, but in the other we have this hyperkinesia, right? Hyperkinetic syndromes. Okay. Pamela, is it good? Not good?
It's like every part is just like a balance of between activation and inhibition. So if you lack one, the other one like compensates. So it's disrupts the cycle, right?
Exactly. So there needs to be it's a very, very tight balance. I mean, the brain, everything depends on the tight balance between those, between excitation and inhibition. So just try to think like, I mean, I know it's difficult to understand this all of the different nuclei, but what you need to know is like the difference between Parkinson and these hyperkinetic ones. In Parkinson, we need to boost and to push the dopaminergic the dopaminergic neurotransmission, and in the hyperkinetic syndromes we have to diminish that. Okay, questions? No? Okay, that's great. So I'm gonna stop sharing this one. I'm gonna send you this today. Then we can start with the next topic. Okay, here we go. Can you see the presentation? So what do you think that we're gonna check now? What is what do we need to understand from here?
Maybe neuropathies.
Neuropathies, yeah. But first, what do you remember from the physiology of the muscle?
That it contracts thanks to the acetylcholine.
Sorry again?
That it contracts mainly due to the acetylcholine.
Yes. I mean, yeah. I mean, depending on the muscle, but yes. What else do we need? So then, if we have acetylcholine, then what do we have there? Why
Then
do
we
we?
have, sorry.
Yeah. Sorry.
I think it increases the release of the intracellular calcium.
Yeah. So basically, what we have there is a connection between the muscle cells and the neurons, right? So we have this, that is the peripheric nervous system, and that's why we're checking these pathologies in this course. So just for you to remember this one, so here I have like the Huntington chorea. This is a video. Sorry. So this is how it looks, chorea. So these movements are involuntary, which it doesn't look like that abnormal, right? But that's chorea. And then, for example, atelectasis, this and it's for me, it's a bit crazy to think that just because some of neurons are not working properly, just one nuclei in that circuit, they are dying. This is the effect that it can have in our body, right? I mean, I don't know. So I'm just gonna put this video for you to remember this. It's nothing that you don't. I mean, the exam doesn't bring in any of the muscle, but for us to understand what we are talking about in this, we need to remember the muscle construction.
Will the exam have images?
Sorry?
Will the exam have images?
A couple of them, yeah.
Like
Yes.
what kind? Like
Like for
like
example,
different
remember
symptoms?
when we were checking seizures, what were the difference in the EEGs, right?
Okay.
And so in the I mean, I think it's very easy for you to learn about, like, to identify this when you have these pictures. I think it's not that complicated. So that's something that comes to my mind. But yeah, I mean, I cannot give you more than that. But this kind of figures.
Yeah, okay, thank you.
Okay, so I'm gonna share this, and then I will ask. So the question was, yeah, okay.
At the basis of all skeletal movements, skeletal muscles are composed of muscle fibers which in turn are made of repetitive functional units called sarcomeres. Each sarcomere contains many parallel overlapping thin, actin, and thick myosin filaments. The muscle contracts when these filaments slide past each other, resulting in a shortening of the sarcomere and thus the muscle. This is known as the sliding filament theory. Cross-bridge cycling forms the molecular basis for this sliding movement. Muscle contraction is initiated when muscle fibers are stimulated by a nerve impulse and calcium ions are released. The troponin units on the actin myofilaments are bound by calcium ions. The binding displaces tropomyosin along the myofilaments, which in turn exposes the myosin binding sites. At this stage, the head of each myosin unit is bound to an ADP and a phosphate molecule remaining from the previous muscular contraction. The myosin heads release these phosphates and bind to the actin myofilaments via the newly exposed myosin binding sites. The two myofilaments glide past one another, propelled by a head-first movement of the myosin units, powered by the chemical energy stored in their heads. As the units move, they release the ADP molecules bound to their heads. The gliding motion is halted when ATP molecules bind to the myosin heads, thus severing the bonds between myosin and actin. The ATP molecules are now decomposed into ADP and phosphate, with the energy released by this reaction stored in the myosin heads, ready to be used in the next cycle of movement. The myosin heads resume their starting positions along the actin myofilament and can now begin a new sequence of actin binding. The presence of further calcium ions will trigger a new cycle.
Okay, so that's it. So we need to understand that we have the two components, right? So we have the neurons that actually send the signal to the muscles to contract, and then we have all of this contraction on this neuromuscular junction, right? So questions on that? So we know that these neurons are actually acetylcholine cholinergic neurons, and then we need calcium, so we need ATP, we need energy, and all of this. So this is the basic that we have to understand to check the pathologies that we need to check. So if we start from there, from what there's going to be 3 diseases that we're going to check during today and Monday, and with that we're going to finish the course. So the first one is diabetic neuropathy. So diabetes. Guys, remember, like, I have always very few people or always the same people participating. So that's 1 point of the final node. So if you don't participate in these days, then you're gonna have zero. I mean, I'm not gonna give anything to compensate this. So diabetes. What do you remember from diabetes?
That diabetes basically is a type of disease in which there's either insulin resistance or no insulin production in the body. And if it's not regulated, it starts generating high glucose levels in blood. And this, as a consequence, can generate diabetic neuropathy and other types of complications all over the body due to the high levels of glucose.
Yeah, good. Thank you, Laura. But then, what it is? Why we have? So yes, we have glucose, high concentration of glucose in our body. We don't have insulin. Why does that affect our body?
Well, in the case of neuropathy, this hyperglycemia, continuous hyperglycemia condition, damages the nerves through different mechanisms, um, like uh, oxidative stress, and then I think I'm not very I don't have, but there's metabolic injury through
Yeah.
through I don't remember what, but I remember there's metabolic injury.
Okay.
And in general, the nerves are damaged.
Okay. I mean, you don't. What I want you to take from me, during this small course that we got, is that what happens in the brain and what happens in the body in general, it is uh, uh, very. I mean, it's very common. It has everything makes sense. It's common sense. Like something happened, some systems get dysregulated because this or that, and that was gonna give us a result, right? So this is how our brain, how our body works, and then, for example, now Ana Sofia is talking about how the brain, how not how the brain, how the glucose and affects the nerves because of oxidative stress. That's actually very good. What else happens? Don't think about the neuropathy. Think about in the body what is happening if we have high levels of glucose.
There is
So
an
I don't know if
accumulation.
I'm not sure. Sorry, I don't know if someone was gonna say anything.
Oh,
Ay,
okay.
perdón.
I mean, go on
But
there.
we have problems with the vessels and how the blood flows through the body. So
Okay, wait, there. Why the blood flows through the body? Why does change?
because of the glucose that is, ay, se me olvidó cómo se dice en inglés. The yeah, like the vasoconstriction of the, pues sí, yo de,
Yeah, I mean,
ajá.
it can be because I don't know if it can be because of that, but we also need to think that the actual blood is changing, right? The composition of blood.
Yeah, well, I think it's a combination of both, right? Like
we are having problems with the vessels, and actually the blood has a different consistency, so it affects like both of them.
It's more because of what, like, we have to clean our like this vasoconstriction that we have. It's also because we need to get rid, like the body feels like sense the osmolarity of the blood, and that shouldn't be like this. What are the symptoms of the diabetes?
That people may feel they have high, I don't know if I'm correct, but high pressure maybe it can affect them.
There are three symptoms. Who remembers those?
Polyuria,
Polyuria,
polydipsia,
polydipsia,
and
and polyphagia.
polyphagia.
Yes. Okay. So why do we have polyuria, polydipsia? What is polyuria?
That you feel a lot because of like the glucose, it generates a gradient that it makes water like be more, como que hace que el agua salga más por un gradiente de concentración que lo une a la glucosa.
Exactly, because we have a problems in the osmolarity of our blood. So that will generate that our kidneys, they need to work more to try it, like, because of this gradient that is unbalanced. And polydipsia is exactly because of the same system. So then we have that all of our osmolarity and all of our system has this kind of problems. So we need to go to the next. Then we have the metabolic and energetic process. We don't have enough glucose inside of our cells for them to develop their work. But what happened with the neurons? So why do we need insulin? First question. Answer. No, go, Love.
To aprovechar the glucose that you're consuming.
How? I mean, why do we need?
To generate energy?
No. The insulin has one function. What is the function?
Insulin? Yeah, to regulate the glucose blood levels.
No, it's not their function to regulate them.
It's a neuropeptide in the brain, right? The insulin.
No.
Glucose.
Estrella?
Store glucose.
I mean, it has a pathway that can store, but it's actually even more basic function of insulin.
It's to open channels so that glucose can enter the cells.
Exactly. I mean, it's not. I don't think there's channels, but I don't remember right now. But what we need the insulin for is because some cells in our body, they need the insulin as a coenzyme to transport the glucose from the extracellular space to the intracellular space. So that is the basic of diabetes. The cells cannot, I mean, the type 2, for example, that the insulin is not actually working. So the insulin cannot help to the glucose to go inside of the cells. And the cells, they are not getting their glucose for the metabolic purposes, right? So that's what happens. And then if the cells are not transporting glucose, what are the cells going to tell to the brain? Where does the polyphagia comes from?
From this signaling of the lack of glucose.
Exactly. So all of that is a loop, and that's why diabetes is so fucked up in many senses. But what is the difference between most of the cells on the body and the neurons?
That the neurons don't regenerate as easily and fast than
That's
the other
one.
cells.
That's the most important. But in this glucose transport,
That they are like, it's literally their main source of energy, that they consume a lot of glucose.
yeah, that's very important. So our brain cannot stay without glucose. So what did our brain did, or our physiology did in that case?
Like stimulate hunger.
No, in the difference with our cells is, or brain cells or neurons, etc., is that they don't need insulin as a co-transporter of glucose. So what will happen if we have a lot of glucose in our body?
It can become toxic to the brain.
We have too much glucose, and this is one of the bases of the diabetic neuropathy. Okay, so you see that everything is logic. That's it's just very logic how our body works, and we just need to remember some details of how everything works. So, diabetic neuropathy is a loss of sensory function beginning distally in the lower extremities that is also characterized by pain and substantial morbidity. Is diabetic neuropathy is half of all the polyneuropathies that we can find. Diabetic neuropathy is present in 10% of the 236 million people that suffer from diabetes. And what the pathology that we need to check is that there are abnormalities in the axon and the myelin components of the nerve fiber. Okay, so we have both of them. So what is happening here is that there is a cell injury in the there is a cell injury in the dorsal root of in the dorsal root ganglion of these neurons, which will impair the protein and lipid synthesis and will affect the axonal transport of everything, right? And actually, basically, the action potential. Why the distal limbs are more affected? So in the pathophysiology, what I'm telling you is that the neurons in the dorsal root ganglion, they start having problems. I'm going to explain you why now. And that will affect the transport, the action potential and the connectivity between the muscle and the neuron. Why the limbs, the feet, the hands are more affected?
Maybe because, I don't know, because they're farther away and the connections are like finer than if like in the plexus and in closer areas to the body. So they're more affected by these functions.
It's logic, right? So if you have like the communication from the neuron to the muscles you have them very long, far away, then you these neurons they need this information needs to be transported from a long distance. This makes that the neurons they make them more liable to have problems, to that the axons died and then they start degenerating. So also we have problems with the demyelination of the Schwann cell dysfunction, nerve fiber changes, vascular abnormality because of the diabetes. Then there is a marker thinning of the basal lamina in the microangiopathy. So this is something that we were also talking, the vascular abnormalities and in the capillarities. I have it 2 times. Yeah. So, and this is the logic of this. So we have hyperglycemia, elevated blood glucose levels that lead to increased glucose uptake in nerve cells. So if we think here, to go to the neurons again, we don't need insulin. So the diabetes, what is causing is not because of the lack of glucose in the neurons, but because of the excess of glucose in the neurons. And our neurons are very bad on generating to store this glucose. We cannot. So what the neurons do, we have this sorbitol system or pathway. And what we have in that by these 2 enzymes, we are gonna produce fructose. So here we say like the polyol pathway, this orbital pathway is actually less efficient in nerve cells, which this will generate 2 things: sorbitol and fructose that accumulate in the nerve cells, which will generate an osmotic stress and cellular damage. That accumulation will contribute to the axonal damage and development of diabetic neuropathy. So this is very easy pathway of, so you have to actually memorize this and all of these the different enzymes and products of all of this. I'm joking, it's not true. So what you have to understand is that we have the glucose that goes to the glucose goes inside of the cell, and then here we have inflammatory signals that will generate 2 things: the polyol pathway that I'm talking about, that will generate more sorbitol, osmotic stress, and then the release of ROS. What is ROS?
Reactive species of oxygen.
Yes, reactive oxygen substance. So this oxidative stress, what it will generate is that DNA damage, endoplasmic reticulum, mitochondrial dysfunction as well, and it will lead to apoptosis. So the main problem with the sorbitol pathway, with the polyol pathway, is that we are going to generate an increase in ROS. Okay, that could we agree on that? And then what we have is here, and this is this is the pathophysiology of all of this. Again, we have hyperglycemia that induces polyol pathway activity, accumulation of sorbitol and fructose in nerves and secondary axon damage. Then we have microvascular disease in peripheral nerves leading to nerve ischemia and hypoxia. So generates less oxygen to the nerves, nerve cells. We don't have neurotrophic factors to protect these cells, and for some reason we have a vulnerability of mitochondria in these sensory neurons, which will produce oxygen, reactive oxygen species or ROS, which damage the nerve fibers. So this is the progression of the disease. Basically, we have initially affects the toes bilaterally and symmetrically. There is loss of small myelinated axons, which will diminish the sensation and the perception of pain and temperature. As axon loss progresses to involve the foot and the lower leg, the numbness ascends with it because of the inability to appreciate pain, injuries of the foot and ankle, and lead to secondary foot ulcers. So this is what we get. And this is the other part of the physiology that is crazy. I mean, there are scary stories of patients coming with a dead foot to the doctor when it's actually black, and then they come and they tell me, I mean, yeah, I have this black, I don't know why it doesn't hurt. Why it doesn't hurt? Because you don't have any sensation or any terminals, sensitive terminals in that area because of the death of the neurons. So if we think about it, this is a very logic what it happens in how we can actually find these things. So people with diabetes, they have to be very taking care of the feet to check if actually they start appearing these ulcers there and treat them as soon as possible. Foot pain. The pain typically described as burning, constant, prickling, and painful to light touch. Might be so uncomfortable that the patient seeks medical attention. The pain may be more severe at night and cause disruption in sleep. This is in the first stages. Large sensory myelinated axon damage is subsequent to the loss of vibration and position sense in toes and feet, which will produce gait and balance problems. And yeah, so this is what I was telling you, right? So we have the hands and the feet reflexes that are diminished as this is progressing and it's not taken care of. Then we will have sensory loss, and the hands will go after the feet, because if we have here the root ganglion, so the hands are closer than the feet, right? So this is what you like. We have all the way of the legs. The axons go from here until here to the spinal cord, and then from here to here. So it's not that long in the hands, but it affects that. Question: how would you treat these patients?
By controlling their glucose levels?
Yeah. I mean, it's a logic, right? I mean, there is not another way to treat this. Good control of blood glucose can slow, halt, or reverse progression of the neuropathy, but it's depending of if you are losing also the muscles and then you are losing that part. Exercise, hypoglycemic agents, etc. Then, I mean, proper footwear to minimize foot and ankle trauma. That's what I was telling you. Inspect their feet for signs of infection, ulceration, then to place their hands in shoes to detect objects that they cannot be feel in the feet anymore. Questions? Easy or not easy?
I have a question.
Yes, Luna.
With these patients, we can also give them like medicine to treat pain, right? Like pregabalin and gabapentin.
I mean, yes, that like the pain is in the beginning, or what was your question?
Yes, that, but I mean, if we give them the pain management at the beginning and we somehow with the glycemic control medicines we manage to help those patients with their glucose levels, do we stop giving them the pregabalin?
Yeah. So the main thing, I mean, this is happening in these neuropathies, that the like how the patients are losing their eyesight is just because of this balance in the glucose metabolism. So as long as everything comes, so like in the good thing is that the neurons, the terminals can regenerate. The Schwann cells can actually also regenerate the myelin, and then they can actually help to conduct the information. But the problem is that when the cells are dead and they don't feel pain, so actually pain is a good sign, and then you manage it and until it's manageable, and then when people are recovered in the sense of their glucose levels, at some point they won't need anymore the pain management. Cool.
Okay, thank you.
Yes. So let me check. More questions? No? Okay. So please, for the next time, we're gonna check what is myasthenic syndromes and muscular dystrophies. If you can read something about it, it will be better for you that you come with some knowledge about this. The last two subtopics of the course. So yeah, on Monday we're gonna finish the course. I mean, I'm gonna stop recording now.